Welcome to Manual Therapy Monday, and so today we're going to be talking about cervical spine mechanics and mobilization of the cervical spine. And so the reason why we're going to do this is because I find a lot of times as clinicians we don't do a great job of palpating the cervical joints, and we don't really kind of get into the joint and move it as much as we should with our manual therapy techniques. So stay tuned to the next couple of videos where we're going to review basically the hand placement. We're going to then talk about the mechanics of the cervical spine, and then we're going to actually show you how to mobilize the cervical spine. So the first mistake I see a lot of young clinicians and students make is not knowing the biomechanics of the mid-cervical spine before they even go mobilizing it. So you really have to know the biomechanics cold if you really want to get the effect at what you're trying to do. So if you look at the mid-cervical spine, it starts from C3 and goes down to about C7. And you can think of your facet joints that kind of lie in this 45-degree plane, and that's how they're kind of angled. And so when I move my head to the right, for instance, my cervical spine on the right moves down and back, but on the left it goes up and forward. So if I have limitation in right rotation, it could be either it's not up gliding on the left or it's not down gliding on the right. So knowing this is very important for your treatment, because if you're not providing the right mobilization technique or glide, you're not going to get the adequate response, and in this case, increasing right rotation. So the second thing that young clinicians and students make when mobilizing the mid-cervical spine is their hand placement. So what we're really trying to do is get on these articular pillars or facet joints when we mobilize them. So a lot of times I find that clinicians, they're either forward in front of the facet joints, they're behind them, or not on them at all. And then the third and fourth and final thing would be they're not actually even going deep enough on sinking through some of the soft tissue to anchor on and mobilize that mid-cervical spine. So now what we're going to do is go and apply this with a patient, and where we'll see where my hand contacts should be and where they shouldn't be. Alright, so now that we just talked about proper hand placement, let's apply that concept with a patient. So in this case, I have my patient laying down on their back, and I just have his head turned to the right here, just to kind of expose those articular pillars. So here is one of the biggest mistakes that young clinicians and even clinicians that have been practicing for a while is they don't get on that facet joint. So usually the facet joint is right behind the sternocleidomastoid and kind of in the scalene. So if you can just kind of bring your patient and you want to feel off to the side, you'll feel these bumps and ridges off to the side. So here's the C1 transverse process, and then I just go down, and right back in here you'll feel these little ridges, and that's the articular pillars, and that's what we want to be on. So from here we want to then use our second MCP to hook on that when we're mobilizing our patient. So I want to really make sure I get deep on there, and I hook onto that MCP as I do my mobilizations. Similarly, if I was going to do like a down glide, for instance, I would also want to hook on my MCP on that facet or articular pillar and then glide them down. And then last but not least, the other thing is that clinicians do is they don't go deep enough. They just do this kind of superficial, and sure, you might get some mobilization and movement of the mid-cervical spine, but you're not going to be really specific as you would like. So you got to really sink through, and don't be afraid of hurting your patient, because you're not going to hurt them in most cases. I've been practicing for a couple of years now, and I've never hurt anyone with the neck. So just trust the process and trust your hands, and then from there you can provide a better and more specific outcome as far as mobilizing that mid-cervical spine. Alright, so the third and final thing we want to do is kind of combine all these things. So up to this point, we've talked about the biomechanics of the mid-cervical spine. We then our second thing we talked about was our hand positioning and placement, as far as palpating the articular pillars and the facet joints so we can get on the tissue that we're trying to mobilize. And then the third thing here we're going to talk about is applying and putting it all together. And so that would be mobilizing in the plane of movement of the cervical spine, which is at a 45-degree angle of those facet joints. A lot of times as clinicians, they don't stay within that plane, and they really don't get the outcome or effect that they want when mobilizing. So in this case, we're going to use right rotation, and we're going to work on an up glide and then a respective down glide. So I have my patient here laying on his back, and so I'm going to do an up glide, up and forward to the right, and so I find those articular pillars. And I obviously, let's assume I already reassessed them or assessed them for where the hypomobility may be. Now I want to just hook on here with my MCP, and I'm just going to actually just kind of do a little bit of mobilization with movement as I rotate his neck. And I'm sinking through the soft tissue and really mobilizing that mid-cervical spine at a 45-degree angle. So I'm really aiming kind of for his opposite eyeball to get that facet joint moving up and forward. And then you can see he's kind of cavitated because I was mobilizing it within that plane. So now we're going to apply these concepts with a down glide on the left facet. So we just did the up glide, so now let's do the down glide. So I have my patient here again. I want to just recap the biomechanics. So when he rotates his head to the left, that left facet is going to glide down and back, so that's what I want to do. And I want to aim at a 45-degree angle. So in this case, if I'm on the left side, I'm using my MCP here. I want to aim for his right shoulder when I'm down gliding him. And so I'm going to kind of pull his jacket down a little bit so you can see him a little bit better. And so from here, I'm just going to really sink in and get in there and just kind of mobilize that facet joint. So you can see how well that joint's moving with my hand. But if I were to maybe come at this angle, I'm not really getting any movement or play. And so that's one of the biggest mistakes that young clinicians make, is they're not in the plane of the facet. So you got to really get in there and just mobilize in towards that opposite side shoulder.